In this video, we will discuss factor V Leiden mutation. You should remember that it is the most common inherited thrombophilia. It is caused by a mutation in the factor V gene. As the name indicates, factor V Leiden mutation. So, factor V gene is affected. That leads to resistance in the factor V to degradation. So, factor V is not degraded now. Normally, protein C degrades this factor V, but now protein C is unable to degrade this factor V and results in a hypercoagulable state, and there is a tendency for venous thrombosis. Pathophysiology. Normally, protein C inactivates this factor V'a and therefore limits thrombin generation and clot formation. When there is factor V Leiden mutation, that is arginine is replaced by glutamine, then there is prolonged factor V'a activity because protein C is unable to degrade this factor V'a. Therefore, there is excessive factor V'a leading to excessive thrombin production and a tendency for abnormal clot formation. Genetics. There is replacement of arginine by glutamine and the position is 506. So arginine is replaced by glutamine at position 506. It is autosomal dominant disorder and clinical features are predisposition to venous thromboembolism, that is deep vein thrombosis, and pulmonary embolism are seen with factor V Leiden. Factor V Leiden leads to deep vein thrombosis and pulmonary embolism. Why? I have told you in pathophysiology. Thrombosis often occurs at a young age. So, whenever young patient presents to you with deep vein thrombosis or pulmonary embolism, you should investigate for thrombophilias. Risk increases with pregnancy and also with surgery because these are procoagulant conditions. Oral contraceptives, including those especially who have estrogens, these increase the tendency to venous thrombosis. Immobilization or other required factor disorders can also lead to increased risk of venous thrombosis. There are less chances of arterial thrombosis in factor V Leiden mutation. Diagnosis. The confirmatory test you should remember is genetic testing, that is PCR for factor V Leiden mutation, but the best screening test is activated protein C resistance assay. Activated protein C resistance assay is the best screening test, while best confirmatory test is genetic testing. PCR for factor V Leiden mutation is done and it helps in confirmation of factor V Leiden mutation. Routine tests, that is PT, APTT, platelet count, that are done for any coagulation disorder, these are normal in factor V Leiden mutation. How will you manage? When there is acute thrombosis, then standard anticoagulation therapy, for example, low molecular weight heparin enoxaparin is given as 1 mg per kg BD for 5 days along with warfarin, and then warfarin is continued for at least 3 months. And long-term therapy is based on the recurrence, risk and presence of provoking factors. If there is a risk of recurrence, then you should go for lifetime anticoagulation therapy. In asymptomatic carriers, there is no need for anticoagulation and you should focus on the risk factor avoidance. For example, not using estrogen, contraception, avoid immobility. So in this way you can prevent thrombosis in these asymptomatic carriers. You should also counsel that estrogen containing oral contraceptives should be avoided, smoking should be avoided, and prolonged immobility should also be avoided. Prognosis. In heterozygotes, 5 to 7 times increased risk of venous thromboembolism, while in case of homozygotes it is 50 to 80 times increased risk. So in case of homozygotes the risk is very much increased and prognosis is good with appropriate prevention and management. So this is all about factor V Leiden mutation, that is protein C resistance.